In this episode of the ASC Podcast with John Goehle, we discuss the current state of ASC accreditation and the value of accreditation, and in our focus segment, we interview Tom Terranova with QuadA.
Welcome to the ASC Podcast with John Goehle, the longest-running podcast specifically focused on the freestanding ambulatory surgery industry. We would like to thank our sponsors, Surgical Information Systems, providing cutting-edge information solutions for surgery providers, RFX Solutions, your all-in-one healthcare regulatory compliance software, MedServe, which is the only digital narcotic cabinet specifically designed and priced for surgery centers, helping standardize processes, compliance, eliminate paper logs and prevent drug diversion, and Ambulatory Healthcare Strategies, the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, please visit our website at ascpodcast.com.
Welcome to episode 265 of the ASC Podcast with John Goehle, recorded on December 22nd, 2025, from our studios in Spencerport, New York. I'm Sue Cronkite, your co-host and operations manager at Ambulatory Healthcare Strategies. As a reminder, the regulatory landscape for ASCs is constantly changing. The content in this episode reflects the most current information available at the time of recording. We encourage all ASCs to remain vigilant and keep up with any updates or new guidelines released by relevant regulatory authorities. Joining me today is John Goehle, owner of Ambulatory Healthcare Strategies and one of the leading experts in the ambulatory surgery field. With over 3 decades of experience, John has authored more than 10 books on the ASC industry and is a highly regarded speaker on topics related to regulation, accreditation, and financial management.
So as we come to the end of another year, I do want to wish everybody a happy holiday season here as we come to the end where we probably have another 2 episodes after this one, including our annual look back on the ASC industry for the past year. So today we are kicking off a new series on accreditation organizations. Mm-hmm. Over the last year, we've been talking to the various accreditation organizations about the value of accreditation and asking them if they would be willing to talk to our podcast audience. And we are in the process of working with as many as we can. And today we're gonna work with QuadA. We're gonna do an interview with QuadA to kick it all off. Let's start with a conversation though about the current status of accreditation in the ASC industry. And we'll start by defining accreditation. Accreditation is an external review process that verifies compliance with established quality and safety standards. And it's designed to promote patient safety, to support continuous quality improvement, and to enhance the credibility of the ASC with payers, partners, and with patients. The way I look at it, Sue, is CMS and the state regulatory authorities define the baseline for your regulatory framework in an ambulatory surgery center, the kind of the minimum standards that are required in order to become a licensed and a certified ambulatory surgery center. Accreditation takes it another step further. It says, I don't want to just meet the minimum. I want to be better than just the minimum. And that's why accreditation organizations came along. Now, accreditation serves many purposes, and in some cases, in some states, accreditation is actually required to maintain your ongoing license. But accreditation in general is considered to be a gold standard for an organization to prove that they want to do more than just the minimum. At the present time, there are 5 accrediting organizations out there that serve the ambulatory surgery industry. AAHC, or the Accreditation Association for Ambulatory Healthcare, very much an ambulatory focus, as you can tell from their name. And they are by far the largest organization serving the ASC industry. In other words, more ambulatory surgery centers are accredited with AAHC than any of the other organizations. Next is the Joint Commission. Of course, the Joint Commission is very well known, particularly in the hospital industry, as well as in other healthcare industries. They have a broader scope in that they serve a lot of different healthcare providers. And they, of course, have been involved in the ambulatory surgery industry right from the very beginning. And then we have QuadA, which started out in plastic surgery largely. It's very much a physician-oriented organization. And they've changed their name. They used to be the American Association for Accreditation for Ambulatory Surgery Centers. And, of course, that is a very complicated name. And they were always kind of called QuadA until they officially made it QuadA. ACHC is kind of a newcomer to the industry, though they're not newcomers at all. They actually are the successor to HFAP when HFAP merged with ACHC. And they have been expanding into the ASC programs and are kind of growing pretty rapidly in the industry. Definitely an organization that you need to keep an eye on. We're going to be having an interview with ACHC actually next after this QuadA, which we're doing today. And then the newest member of the ASC Accreditation group, and that's DNV Healthcare, which is an ISO-based organization. They started out as a accreditation organization for shipbuilding, of all things, in the 1600s. Very, very old organization. And they got into healthcare, or they got into hospitals specifically, a little more than a decade ago. And now, as we're sitting here in the fourth quarter of 2025, they are just starting to accredit ambulatory surgery centers, and definitely an organization to keep an eye on. I think what we're going to find with DNV is a lot of hospital-owned or hospital-affiliated ASCs will probably choose to go with DNV if they are already with DNV on the hospital side. So what we're seeing here is definitely a trend toward increased competition. And we're hoping that, and I expect that this is going to lead to better customer service. I think overall the organizations, all of them, have become somewhat complacent when it comes to customer service. And we definitely have seen an improvement in the approach to customer service with all the accreditation organizations that we work with. And, of course, there's a big move toward technology, improving the technology, the back office support that they have for the organizations, moving as much as possible to online resources for ongoing compliance with the standards for each of the accrediting organizations, as well as just having access to the standards online is helpful, and enhancing the survey experience. Another thing that we've seen recently, of course, is many of the accrediting organizations have been speeding up the process for giving you feedback on the results of an accreditation survey. For example, Joint Commission will provide you a report at the end of the survey, which has most of especially the major citations that you'll have. AAHC has followed up, and they're now providing a relatively simple report within 48 hours afterwards. So definitely technology is improving the responsiveness of the accrediting organizations and providing feedback to the ASCs. There have been a lot of questions recently about how easy it is to convert from one accreditation organization to another, and certainly we as a consulting company, the consulting side of our business, have seen an increase in questions from potential clients as to whether it is possible to change and if it is and how difficult it is to change. We're going to talk a little bit more about that in future episodes, and we're also getting a lot of questions about the differences between deemed status surveys and non-deemed status surveys, which I think we'll address in our next accreditation-oriented podcast. So stay tuned with us as we delve deeper into the various accreditation options. But for today, let's focus on QuadA with an interview with Tom Terranova with QuadA. So we'll take a short break, and when we come back, we'll have that interview.
If you work in the ambulatory surgery center industry, whether you're an administrator, a nursing leader, a medical director, an owner, or part of the clinical or business office team, there's one resource you should be using to stay sharp, stay compliant, and stay ahead. ASC-Central.com. ASC-Central is the premier online hub for ASC education, leadership development, and ongoing professional support. It brings together decades of ASC expertise, practical tools, and industry-leading training programs, all built specifically for the challenges of the ambulatory surgery environment. One of our most popular offerings is our series of leadership bootcamps, the industry's most respected training programs for ASC administrators, directors of nursing, and business office managers. These bootcamps are not passive lectures. They are mentored, structured, immersive learning experiences that walk you through every aspect of ASC operations and leadership. And many of our bootcamps provide AEU credits for CASC, certified administrators, and IPCH credits for CAIP certified infection control professionals, helping you maintain your credentials while you strengthen your leadership skills. ASC-Central also features a comprehensive collection of on-demand educational programs. These are full-length virtual conferences recorded over the past several years, covering regulatory compliance, quality improvement, credentialing, infection control, finance, governing body education, and much more. These programs are detailed, engaging, and highly practical, and many of them also offer CASC and CAIP continuing education credits. For ongoing access and continued support, ASC-Central offers a range of membership programs. Patron membership, designed for listeners of the ASC Podcast, includes access to regular group Zoom sessions, an extensive resource library, and complimentary access to several key conferences such as the Conditions for Coverage, Medical Director, Credentialing, and Finance and Accounting programs. ASC-Central Premium Access, our most comprehensive membership level, includes everything in the Patron tier, plus full access to all leadership boot camps, private consultations, live and recorded conference access, individualized staff training, and ongoing interaction with leading experts in the ASC industry. So if you're ready to elevate your knowledge, strengthen your team, and gain access to the most complete ASC education platform available, visit asc-central.com or email us at info@ascpodcast.com for more information. ASC Central, where ASC leaders come to learn, grow, and succeed.
So I'm here with Tom Terranova with QuadA. Tom, welcome to the podcast. Again, you were here when you first started working with QuadA a couple years ago.
Yeah, thank you. It was when I actually returned to QuadA, probably sometime after I came back in 2019. It was probably not too long after that, but I thanks for having me on again. I appreciate it.
My pleasure. My pleasure. So you're kicking off this series that we're doing with interviewing the various accreditation organizations. And as I said, as we were getting ready for this interview, there's a huge change in accreditation right now, with a lot more competition. And, I don't think that's a word that was out there when it came to accreditation organizations for quite a while. But organizations realize that they do have a choice now. And I think our audience wants to know, what are the differences between the different organizations? So why don't you start with a little bit of a history of QuadA?
Sure. So interestingly, QuadA probably still carries a reputation of being primarily plastic surgery focused because that's really our origin. Somewhere around 1980, really, if you go back a little bit farther, 1977, what is now the American Society of Plastic Surgery, there was a subcommittee that just was charged with assessing what was going on in healthcare, and especially the plastic surgery back then, and what was needed. Kind of just a landscape canvassing of the landscape, we'll say. And that committee came back and said, we as plastic surgeons can't get on the rotation of the hospital. There's always something more important to be done. And so, we're kind of going out into the office. And as one, I won't say it this way, but as one of the contemporaries of the founders told me once, that was borderline malpractice in 1977.
Yeah.
To be doing big surgeries in your office. And so they said, we really need a third-party arm's length process to show everyone that we're taking appropriate protections. We are making sure that, once you kind of roll into the OR, that the experience is no different or no less safe, we'll say, than the hospital setting. And so those folks founded QuadA in 1980, and it began as a purely voluntary endeavor. So in the first year, I think 100 facilities became accredited by QuadA, all plastic surgery.
Right.
Fast forward a little bit, and the specialties started to diversify a little bit, and especially once you get into like the mid 90s. So 1997 was when QuadA first became a Medicare Ambulatory Surgery Center deeming authority, and so that opened the door for QuadA to start doing surveys in lieu of the state agencies that would allow facilities to start billing to Medicare. So that was 97. Right around the same time, California became the first state in the union to require accreditation for the use of anesthesia in the office, and basically anything from sedation up. And that led to an explosion in sort of the diversification away from strictly plastics. And so, again, if I fast forward, some more states have kind of followed suit with California, New York, Florida, Indiana, Washington has a very similar rule. There's 20-something states have something on the books, whether it's a recommendation, a guideline, a mandate, a law, kind of varying degrees of strictness. About 27 to 30 states have something on the books pushing people towards accreditation. And so now, if you look back when I started at QuadA originally in 2009, well over 90% of our accredited facilities were still plastic surgery.
Yeah.
As of today, it's about 40%. And it's not that the plastic surgeons have gone anywhere; it's that all the other specialties have grown up around us. So we have this historical kind of tie to plastic surgery. But as it is now, we accredit across every ABMS specialty, all the osteopathic boards, podiatry, dentistry, and even primary care. When it comes to some of our specialty programs in rural communities, which are primary care, that's primarily nurses, NPs, PAs, even midwives. And even in our therapy world, we have accreditation that touches OT, PT, and speech. So our world has become much more dynamic, has become much more diversified, and has become much more sophisticated in that journey from 1980 to 2025, where now we accredit over 3,000 facilities. Some of those facility programs are allowed to have satellite locations. So we're kind of approaching 4,000 locations. It varies, of course. We're approaching 4,000 locations worldwide. We've worked at one time or another in 22 countries and are active right now in 15 countries. So QuadA has become, again, much more sophisticated and diverse in terms of geographic location as well. But the truth of it, what really comes to the core of it, is that QuadA is a tax-exempt nonprofit organization. So even though we work in this way to accredit facilities, to bring quality and safety to facilities, because we're a tax-exempt organization with no ownership, our mission gets to lead the way. And so we really try to do everything we can with the mission in mind of patient safety and just sort of driving towards the patient safety goals. So it allows us to have every strategic conversation, every conversation that we have with our clinical teams and our committees to really lead with safety and quality before we have any other considerations, which I think is incredibly freeing as an organization.
So how many ambulatory surgery centers, Medicare certified ambulatory surgery centers, do you accredit?
Yeah, from an ASC standpoint, I can give you the percentage. I'd probably have to do a little math in my head.
No, it's all right. Yeah,
it's about 15% of our total population. So, if you figure 3,000 facilities, what is that? 450 or 400 facilities, something like that in the ASC world is ours. It's probably right in the middle of the pack in terms of our 10 or 11 programs.
Gotcha.
It's surgery and office procedural, which would be, they could be small, they could be massive multi-specialty facilities. They're just not billing Medicare.
Right.
We have one that I can think of that has like 125 docs and 12 ORs. Those facilities, those two programs, which is be non-invasive as well as invasive, are about 24 and 26% of our population respectively. So when you're talking about people using anesthesia in an OR on an outpatient basis, it's, all told, probably about 65 or 70% of our business.
Gotcha. So the OBL, or the office-based laboratory, office-based surgery, is a very big part of your business then.
Yeah, that's the lion's share. And procedural, which would be like gastro and urology, people who are doing scoping type of procedures and injections for like pain management, those folks would be like the second largest group.
So I think a big question that our audience probably has, and certainly a question that's asked of me from our clients, is, what makes QuadA different? You already talked about your history, obviously, but talk about the way you approach surgery accreditation, and why would an organization? I think it's important to note that people are looking
at all of the organizations now and wondering which one is going to be the more appropriate for me. It's not so much, the competition isn't so much, which one's going to offer the cheapest. Obviously, It's more which is going to match up with my goals and objectives and my organizational structure.
Yeah, I think that's a fair question. And, you allude to competition and we talk about it being sort of a new dynamic in the space. But the reality is, since I've started, since 2009, we've talked about there being kind of a friendly competition among the accreditors because, at least from my perspective, I have a mission to uphold. And that mission is to promote and facilitate patient safety as much as possible. And so there was space for all the accrediting organizations.
Yeah.
And it becomes what fits. What's the rightness of fit that you have? And so I think there's space for the organizations, and I certainly don't denigrate any facility for choosing to go with an accreditor that's other than QuadA. The facilities I struggle with are the ones who choose not to get accredited.
Yeah.
That's what I've always said in talks. If you choose one of the other organizations, that's up to you. They all do a very nice job at what they do. I'm certainly biased toward my program and toward our process, and I'm sure they are toward theirs. But the reality is, I'm okay with a facility choosing one of the competitors. I'm not okay with a facility choosing to just forego accreditation entirely because that violates my mission. So I think that's the foundation we have to start from. We all do a good job, and now which one fits, right?
Right.
And so for me, I do have the benefit. Certainly I am biased, but I feel I have the benefit of being able to wholeheartedly and honestly say when I'm in a room, whether it's with a regulator or a facility, that we have both the most streamlined and appropriate and best program for accreditation of outpatient centers and the most cost effective. And I think while we talk about money not really being the key driver, and we certainly don't want to race to the bottom, as a nonprofit organization, we're not out there kind of searching for profits, and we can try to make things as reasonable for facilities as we can. We do everything we can to make sure that it is digestible for the small facilities. And that goes not just from an economic side, but it also goes from an accreditation standpoint. The requirements that we have are, to my knowledge, and in comparison with everything I've seen from all the accrediting organizations, the most targeted and to the point. And partly that's by design. Our origin story is that of solo practitioners. Mm-hmm. If your origin story is large academic hospitals, your philosophy and the lens through which you view safety is going to be vastly different. And you can carve out and cleave off large chunks of your program to try to fit them to an office-based center with one or two doctors. But that's not necessarily going to work appropriately. We all know, sometimes you cleave things off and there's gaps, so there's overhangs. And I think if you have a philosophy of hierarchies and committees and structures and departments, it's really hard to swing that around. So the first thing I always talk about whenever a facility asks why QuadA or what about QuadA really works is if you're a small to mid-sized facility, that clarity, that simplicity of do X, do Y, rather than establish a committee to decide what X is and then figure out what to do about it.
And have 10 or 12 different directors, overseeing
Correct.
all the different aspects.
Who are the stakeholders? Well, it's me, it's my wife, it's my son, it's my husband, whoever, right? There's hard to establish a committee there. Yeah. So for me, the very first part is if you're a small to mid-sized facility, that clarity and simplicity is essential. If you're a large facility, it's a benefit, right? It's it's more clear. It's more clear cut. So I've long defined that there's a very big difference between easy and simple. Accreditation through any organization is not going to be easy because it requires dedication, it requires discipline, it requires follow through that is challenging when you're a busy organization. But simplicity, clarity is a huge advantage, and it's essential for a small facility. If you want to get down to kind of really, really precise differences or precise what I'll call differentiators that really, in my opinion, make QuadA special, there's typically four that I point to. One is I think our requirements for who can perform what procedures in a QuadA accredited facilities are the most stringent. Now, I say that, and that could turn people off, and that's okay because, our board has decided that is one of the most critical things to establish at a baseline the competency and ethical behavior to perform certain procedures. So we have, my understanding is, the most robust and the most strict requirements for what you can perform in being core to your specialty and your training of any accreditor. So while some people might look at that as kind of a pain in the neck, from us, it's a differentiator in terms of, if you're carrying the seal, if you're carrying our accreditation stamp, you know that the people are sticking to specialized training that they've had, that's robust and that is complete. So I think that's kind of number one. Number 2 and 3, I would say, are highly aligned and highly related, but I do like to differentiate them. QuadA has a 100% compliance mandate. And so my understanding, again, is that we're the only accreditor really in the world that has this. Even in other countries, I've not run into this. So QuadA's 100% compliance mandate says, once we've determined that certain standards apply to you based on your equipment or the anesthesia that you're using, whatever it is, once we've decided which standards apply, you have to meet all of those standards in order to carry accreditation. And that means if we cite deficiencies, we go through the corrective action process with you, but we want to see that they're all done. And again, by the time you hang that certificate on your wall or put it on your website, that you have met every single criteria. There's no advisory opinions. There's no recommendations. If it's a deficient, it's got to be corrected. If it's corrected, we're good to go. So again, can be seen as a little bit of a pain in the neck, but I always want to caution a facility who would see that as a pain in the neck to think about their daily operations. Again, as a small to mid-sized facility or even a massive facility, we're all way too busy, all of us. That's just the nature of our world. So once you get busy, it's really hard to kind of clean up those things, those follow-ups. Because we sit through the process with you, and that will lead me into the third differentiator. Because we sit through that process with you, we're kind of setting you up for long-term success, because we're not saying, hey, don't forget those 3 things that we didn't really like, but we didn't want to hold up your accreditation for, because you're going to forget them. You're going to have meetings, you're going to plan them out, and then you're going to get really busy more likely than not, and you're not going to be able to follow up on them. So we carry that process through, and that's the third differentiator. So in conjunction with the 100% compliance mandate, we also require facilities to work with us through evidence of correction rather than plan of correction before we'll confer accreditation. So to educate anybody who doesn't know, like when they go through the Medicare process with the state agency, and to my understanding, many of the accrediting bodies, once you are cited for deficiencies, you establish a plan of corrective action and you say, here's what I'm going to do in order to correct this deficiency, and here's who's responsible for it, and we're going to have it complete by this date, and this is how we're going to monitor our ongoing compliance. Once you have that plan, the states approve you and you move on with your approval from the state. And to my knowledge, some of the other accrediting agencies, I'm obviously not super privy to all of their internal workings. Mm-hmm. QuadA, on the other hand, says, okay, that's a great plan. Now show me you did it. So send me evidence of corrections. Show me your work order. Show me the photo. Show me the new training you did. Show me the new policy you did and the sign-off sheet for your team getting trained up on it. What that does, again, in conjunction with the 100% compliance mandate, is to say to busy facilities, we're your partner all the way through the time when you showed us that you knew how to do it, and when you showed us the capacity to be compliant, so that when you hang that certificate on the wall, you know you've crossed every T and dotted every I, and that you're capable of staying in that lane. And certainly there will be drift from time to time, but it's more of a partnership to bring you across the finish line so that you're set up for long-term success. And I know I kind of took a long time on those first 3, but the fourth one's a little bit simpler. The fourth one is our data collection. Mm-hmm. So QuadA is the only organization, again, that I know of that has mandatory data reporting for every physician working in every facility. And it's a low burden. It's basically, we collect the number of cases that every facility does. We collect 3 random cases from every operating physician. And it's real basic data, all anonymized and de-identified and aggregated. We don't know, which facilities are reporting necessarily which things. We keep that separate from the studies. And then we collect all the adverse events. And the reason we do this is because there is a dearth of information in the outpatient setting. Our board back in 2001 had the foresight to put in this program to say, we want to be able to prove out the safety of what we're doing. to tie in our standards to safety, to change those standards over time if they're not impacting safety. And we think about changing standards in terms of ratcheting them up. But in some cases, we say, look, we see no difference if this standard's in place or not. Let's take it away. Why have additional bureaucracy and burden? Let's make this more reasonable. And so that data reporting is massive, and it goes to really large institutions and research partners. Our closest research partnership is with a group of researchers from Harvard, but we have research that come out of UC Davis, that's come out of University College London, that shows and validates the premise that accreditation, and particularly QuadA accreditation by people practicing within their specialty, leads to the safest possible outcomes, either on par or better than hospitals and licensed facilities. And I'll just give one short example of it. The most recent study that we released about a year and a half ago, we're doing a fifth in a long longitudinal study. About the fourth one, it came out about a year and a half ago, tried to correlate the data that we collect with deficiency data from QuadA surveys. And so we have a requirement that any facility, before they conduct a case, do a DVT, VTE screening to understand how susceptible the patient is to DVT or VTE, and to decide if there needs to be any sort of prophylactic measures to protect the patient. And there are certain that are required if the case goes too long or not, but essentially it's about awareness and decision-making. What we found, what the Harvard researchers found, was in every year that those deficiencies rose for that standard, meaning facilities were not complying with that screening standard, the number of adverse events and deaths related to DVT and VTE increased. The years that the number of citations decreased, meaning facilities were already doing this, they were compliant, they weren't missing these screenings, adverse events and deaths dropped. And I don't want to go too data nerd on anyone who's listening, but the Harvard researchers were giddy. They said, I've never seen a correlation this tight before. And so that's the approach that we take. We want to take that academic approach to prove out the value of what we do. And I just want to end on this point with any accreditor, QuadA or any other. I caution facilities not to see this as a burden, as a problem, as a mountain to climb. See it as a partnership towards safety. See the value added. If you could look at a study and say, by following this, I am making sure, and I have a third-party partner to make sure that I am less likely to bring a patient down a road to a DVT or VTE, that's a value to you and your organization. It's a value to the way your organization operates and to risk mitigation. And if you flip the mindset from like, oh, I got to get accredited, what's the least objectionable path? What's the least big thorn in my paw? To this is a huge value add and a protective measure for me. I think, your mind opens up a lot more to the ways and to the philosophy towards compliance. So that's a message I would take to anybody. That's not a differentiator from QuadA to the others, but with the whole concept of accreditation.
I find this is fascinating, Tom, because we just got the final 2026 payment rollout, and I think many of us are frustrated that quality program, the quality reporting program, doesn't necessarily look at measures that are really enhancing patient quality or care or safety. And I think you've just described a situation in which what you're putting together, that let me call it benchmarking that you're doing and peer review that you're doing, is actually can actually demonstrate an improvement in safety in your organizations and obviously quality. If only Medicare could use those types of studies that you've described, perhaps that program would be stronger and much more useful to our centers.
Well, look, I mean, the sad truth is money makes the world go around, right? So almost every benchmarking piece of data I've seen from either an insurer, a health system, or a government is all about efficiency and quality and things. Yeah. That sense of efficiency, right? That sense of safety and quality is more about like turnover and things like that and claims data. And it's not about sort of, the outcome or like the adverse event. So, I think there's a lot of ways in which being a tax-exempt non-for-profit organization with no owners benefits us. And one is it frees us up to ask questions like that. We don't care. We try to stay out of people's pocketbooks as much as possible. And because people get real personal about the money. But if you stay out of the money and you say, what are we doing for healthcare? And we lead with the question is, does this new requirement, does this new standard we're contemplating impact patient safety positively? If yes, then we got to figure out how to be responsible. If no, then throw it out and forget it. There's no reason to add it if it doesn't protect patient safety. And the same goes for cleaving stuff away. I can tell you that we have some standards that we've relied very heavily on data to roll back from being overly burdensome on facilities because there was literally no data showing that it did anything to protect patients or help them in any way other than to delay the best possible care. So, we really lean on that stuff to try to be as impactful and as reasonable as possible.
I did want to point back to your comments about that peer review work that you do. In other words, the requirements that you have with your organizations, which is unique to QuadA, as well as the incident reporting, which is somewhat unique. I mean, many of them have, especially very complex incidents or catastrophic incidents have to be reported. And it just strikes me that you're helping them to meet the benchmarking requirements. You're helping them to meet the peer review requirements. It's almost baked into your accreditation process rather than them having to necessarily create something from scratch. You already got a process there that they can tie into to help meet those requirements.
Yeah, absolutely. And that certainly, I will take a moment to sort of differentiate peer review and what we call PSDR.
Yeah, no, there's only a component. Right, good point.
Yeah, because I do think, it's important. And we sort of say we have two standards, right? You have to conduct peer review, and that's the judgment of technique and medical judgment and having a peer assess that. And ours is really data, patient safety driven to try to look for outliers and anomalies and red flags and things like that. And the two are go hand in hand. And we kind of say, if you've reported an adverse event in the PSDR, make sure that's part of your peer review, because maybe there's medical things that are not compliance-based, because that's a huge confusion point. Things that aren't compliance-based, but that may be judgment or technique-based that we know accreditor is assessing. You want to make sure you put that before your peer who can give you feedback on that. And that should be part of your minutes, and that should be part of your peer review meetings. But we're baking that process in and kind of leading that horse to water in many ways. And I do think that's a strength, especially, again, I don't want to isolate the large facilities, but especially in small and mid-sized facilities, you can get really isolated. And this is a way to break that isolation down.
Yeah, and I think it really does tie that benchmarking or that quality assessment component to the peer review program itself, rather than having to go outside and get it from some other organization, which we still encourage you to do. But here's another option, particularly for the smaller organizations. Tom, there's something that you said earlier I don't want to gloss over. You had mentioned that you have, it's not so much that you're concerned about who you get accredited by, but whether you get accredited at all. And I think that's a wonderful comment here about how important it is for all of those organizations out there to consider that next step up. When I talk about accreditation in my conferences, I talk about certification being that base level. That certification and licensure is the base level, the lowest level that you can possibly accomplish. And that if you really want to prove quality, if you really want to differentiate yourself and demonstrate to your payers, to all your constituents out there, accreditation is absolutely essential. And I think you've described very well where you come in on that.
Yeah, I think. Look, I don't want to denigrate either the job that the states do, but right, like what you're saying is, here's the baseline, right? Here's to open your doors. And I don't know of a surgeon, I don't know of a doctor who wants to be at the entry point. Every doctor I know is a high achiever, and they want to be beyond that. And I think, again, it's all about viewpoint. If you're viewing accreditation, if you're in a state that has a mandate or a specialty that has a mandate, or you're just sort of like gritting your teeth and doing it because you feel you have to, you're not going to get the most out of any accreditation process. But if you're looking to improve and add value to your organization, whether it's operationally, whether it's through leadership, whether it's through efficiency, whether it's through improved safety and risk management or risk mitigation, if you look at those as values to your organization, which they unequivocally are, but if your perspective allows you to see that, you can take a different tack towards it, and you can kind of throw yourself into it much more enthusiastically than you would otherwise. I mean, I have kids, you talk to kids about learning anything that you want to learn, right? And when you're upset or when you're angry or when you're resistant to it, your brain is throwing up these barriers and just nothing will get through, right? Try to learn a language begrudgingly and it doesn't happen, right? But try to learn a language enthusiastically because you fall in love with someone from that country, and it's gonna like a waterfall. The language is gonna pour into your brain. I think it's the same here. We're talking about the language of safety. We're talking about the language not of compliance with a law or compliance with a mandate, but with like blossoming your organization into a better, stronger, more robust organization. If you throw yourself into that, all of these inputs become that much more enriching to your organization and not like the least objectionable torture.
Let's shift a little bit toward the survey experience and the surveyors. I mean, I think, for the organizations, they obviously have contact with the organization through the application process and the ongoing stuff. But ultimately, it all comes down to a survey. So tell us a little about your surveyors, where they come from, what type of training they get, and perhaps what's different about them compared to some of the other survey organizations and how they do that.
Well, the first thing, and I think all the accreditors would say the same, and honestly, I think the states would say the same. The surveyors are intended to be peers. Now, does that mean they're from your specialty? Probably not. We try, but that's not always possible. There is some, sometimes, whether it's a nurse, a physician, whatever, there's some mix and matching there. And I'll just say candidly, not everybody sees every profession as a peer. But, the intention is that we have people that are especially expert in outpatient surgical care. It's hard to have an ER doc. It's hard to have a psychologist or a psychiatrist come in and survey a ambulatory surgery setting, whether it's an ASC or an office. But what I would say is these are people who work in the environment, whether they're doctors or nurses. They work in the same environment, so they have that sort of implicit understanding of what's going on, and kind of they get that feel for the facility the minute they walk in a way that a lay person or maybe someone who works in a hospital setting or a psychiatrist wouldn't. And so I think that can be one point of departure with the states, particularly because the states have a limited resource in terms of who they're pulling from, and they're maybe serving vastly different kinds of providers. Whereas at QuadA, we're really kind of focused in on the outpatient world, so everyone we're pulling from is there. Now, traditionally, our surveyor cadre has come from accredited facilities in a volunteer setting. And so these are folks that come and get training, and then they kind of take a day out of their life and really invest. And they get a benefit too, right? They learn from facilities that they inspect. And so they would come in to do inspections on an ad hoc basis. We have slowly professionalized that crew because you inevitably get someone who trained who did one survey a year, or you never heard from again because they got busy. Or you get some people who are really, kind of doing it regularly. But there's a sweet spot at which you get really, really proficient at surveying. We've tried to kind of bring our cadre into that world where they're doing a few a month so that they really get a lot of at-bats and they really get proficient and they really know what it looks like, because you only know your own facility. And if you're only surveying intermittently, it's hard to get a broad perspective. And even geographically, right? Like surveying in Idaho is very different than surveying in Manhattan, right? The space alone is just a different animal. So we've tried to kind of bring that cadre into center so that they're like quarter time, halftime people. We want them still to be in practice so that they're still kind of current and they haven't really lost touch. We get a good number of retirees, but the sweet spot with retirees is really the first few years after retirement, so that they don't kind of lose touch with new technology or new machines or whatever, especially, in some specialties that it changes so quickly. So that's who they are. They come in for training regularly. When they first come in, it's really a day plus of training. We really try to do in-seat. COVID kind of threw everything off, and after COVID, people still love Zooms and things like this, but there's really no replacement for on-site. So we just actually had a big 75 people in Chicago in March to do a big training with experienced surveyors. So these are already people who are doing this on the regular, and they came in for 10 hours of training, and then they also did some supplements through webinars. Our cadre also gets they do quarterly calls together. And so we encourage them to attend live, but also if they need to do it asynchronously for time zone differences or whatever, they can come asynchronously to share knowledge. So the heads of our investigations committee, the heads of our standards committee, the heads of our QA committee, our internal clinical team will come together with all of our surveyors quarterly to discuss kind of hot topics, to knowledge share. They run kind of Qualtrics surveys to test fine points and gray areas to see what the surveyors answer, and then to educate, because inevitably, you're going to get something where there's differing opinions. So we're trying to regularize And I think this is really one of the big benefits to accreditation, especially for corporates or for multi-jurisdictional entities, is that the hardest thing for any survey agency is consistency, whether it's geographic and inter-rater reliability between surveyors, or I'm tired, or I'm energetic one day, or whatever. The surveys, you don't want them to vary. And so we're doing everything we can to kind of normalize that and share knowledge to say, this is why we made this decision. We can't give you a paint by numbers because every situation is different, but we want to give you as many touch points as a surveyor as possible to kind of refine and refine and refine. So survey 1 looks like survey 9, even though they're in 2 different states. And so that's really the key.
Yeah, having consistency. I think that's one of the comments that we often hear, especially we as consultants coming in, this last survey was like this, but this survey has been completely different. I think all the accrediting organizations really are struggling to try to fix that problem.
I think it's an endless battle, and similar. If you're talking about Medicare, right, especially where you are in sort of a condensed area where it's maybe like Connecticut, New York, Pennsylvania, Jersey. Now you're in different jurisdictions, and if you're dealing with state agencies and you own entities across the borders, you're dealing with wholly different philosophies. If you go to an accrediting agency, you might deal with a difference between surveyor A and surveyor B, but at least organizationally, the philosophy should be the same. So we're trying to regularize that. We have QA processes. We have, kind of mentorship and interventions that help with that. We observe surveys so that we can give feedback to the surveyor. We have walk-along surveys, which a senior surveyor goes with that. A more junior surveyor, either to lead or to sidecar and give feedback. So there's kind of 2 different methods. And then one of the big things too is that we also have an in-house clinical team that once the surveys come in, or if there's questions on site, that team can provide a consistent amount of feedback and directive to the surveyor and to the facility. No, that's not an issue. Yes, it is. Why is it an issue? Let's kind of help navigate this sticky point. And so that team internally helps kind of keep the consistency at the highest level we can achieve so far. And it's an endless pursuit of perfection.
Why don't we talk a little bit about your computer systems? Because ultimately, a lot of the contact that organizations have after that survey is going to be, through your portals, and of course, a lot of the education comes from that. Tell our audience a little bit about about how your system works and what's available on it.
Yeah, so our system is evolving, as any computer system is. There's a saying in technology: everything's always in beta. So I'll say it changes. Whatever I say today will be different in 3 months. But we actually have an entire team to build out our system. It's custom built. So the portal, when you go to it, is not currently integrated with our website. That's one of the things that will be coming on eventually. Is when you go to the website, you just go straight there. Now it's a couple links to click through. But once you log in as a facility, even as a consultant, right, you can manage any facility that you're part of. As long as you're identified as what we call a facility contact, meaning someone who's kind of empowered to act on behalf of the medical director of the facility. And so you can log in, you see all the facilities that you're associated with, you can make your application right through the system. It will bill you automatically. It puts everything out, you kind of fill out everything that used to be on paper, the demographics of the facility, the specialties, the staffing, uploading all the staffing documents, license and board certification and hospital privileging and all of these other things that are required, floor plan for the facility, things like that. Load them all up. The facility director has to sign an attestation about local laws, being in compliance with those, which we may not be as sensitive to, fire code, OSHA, things like that. And then to move on into the demographics and then an auto pay system that you can set up right there. So that should be pretty streamlined. You can save while you're in process. For any consultants listening, if you're kind of a new consultant to us and you're running through the bunch of facilities, we do limit the number of applications you could send in as a consultant, just to make sure we're not getting like AI robot spammed. Yeah. So basically it stops you at 5, but once we approve any application, so that we know you're a real person submitting real information, then it kind of opens the floodgates. So for consultants out there, there's just that one little hiccup just to make sure you're a real live human. But after that, you can apply. Facilities can apply on their own. And then that's really what begins the process of accreditation with your accreditation specialist. That specialist stays through you throughout your life, and that person is there to answer questions. So they'll review the documents that you upload. I always say, especially now that it's digital, we want to make sure you didn't upload a picture of your cat instead of your floor plan.
Yeah.
So we look at that, we make sure it's the right one, we make sure it's consistent, and then the specialists make sure it's compliant, or they'll interact with you to make sure it's correct. Once that's all done, that's when we start working towards the survey. So there's a real big gap in that timeline, and that is the facility's time, right? Some facilities have done all the prep work beforehand and they're ready to go. Some facilities want to ask questions and wait for things to get delivered and things like that while they're setting up and building out. So that time is really personal time, emailing back and forth with your specialist. But then once we get to the survey, our accreditation schedulers will schedule the survey based on the calendars of availability and blackout time and making the time unpredictable and unannounced for Medicare surveys. Mm-hmm. And then they will set that up with a surveyor. Once the surveyor comes on site, everything's done on an iPad or a tablet. They mark the surveys live while they're there. They can take pictures, they can take video notes, audio notes, append that all to your survey, and then they upload that. They have to upload that within 48 hours of the survey. If you have multiple surveyors on site, it's a really cool system. Just to tech nerd out a little bit on it. 3 or 4 surveyors, as they submit things, it gets aggregated, and the lead surveyor then gets to pick. I saw this, surveyor 3 saw that. I'm going to accept surveyor 3's, or I'm going to accept mine, or I'm going to merge the two together. You get a final report. That final report comes to our team. It gets 2 checkoffs. So again, they go through the system digitally and check them off. Once they release it, you get a notification in your inbox with a link to click that logs back into the system, takes you right to your report. So let's say you have 10 deficiencies. Those 10 deficiencies, you have the format and the prompts to fill in all your plan of corrective action. Mm-hmm. So you have to do that for all your 10, and then you resubmit it to us. So once you submit your plan of correction to us, our specialists and our reviewers get a chance to look at it again and to review what you said you're going to do, who's going to do it, when, all those good things. And they can either approve or mark it to send back to the facility. What will happen there is everything has to be done in bundles. We don't want to piecemeal 10 different things, but it gets done in bundles. So when you send your 10 back, we'll review them. And let's say that 8 of them are acceptable and 2 need to get kicked back for some specific reason. We'll mark those 2 to get kicked back. And once we're kind of done scoring every single plan of corrective action, we'll resubmit it back to the facility. Now, our team, there's a little plus button by a lot of these icons. So our team can give you direct feedback. Please add some detail to your monitoring and tracking that doesn't say how frequently you're going to monitor this action, whatever. This way, you'll get direct feedback on the exact element that is missing or that is not acceptable. This way, you don't have to kind of guess. We don't want to just say no and send you back into the wild. Once you do that,
save you time. Yeah.
Well, be real direct and efficient. Once you send that back in, kind of the same process repeats with the evidence of correction. We talked about evidence of correction before. It repeats with evidence of correction. You're doing it all directly in the system with us. You're not submitting things by email. You can upload videos of training, PowerPoints, anything you want to upload, any document type you want will get uploaded, and our people will review that, approve it. It goes to our committee, who also approves it on the portal. Once it's all approved, then the same thing happens with your certificate. Your certificate comes through via email. It is a link. It's a platform called Accredible, which is a digital certificate. And the really great thing about that certificate that actually a lot of facilities are still missing out on, they want to print it. Great, print it out, put it on your wall. But you can also embed it in your website. You can also embed it in your social media. So people can see live and validate your accreditation through social media and through your own website. You can embed that image right there. And as it gets renewed, that gets automatically updated and everything. So it's a really nice, seamless thing that is ever evolving. So there's more to come on it. Facilities also use that same system to do their PSDR reporting. And actually our learning platform is on that system as well. We're kind of refining how we do it so you can choose your journey once you log in. But as of right now, those are all on separate login screens, but all on that same portal.
Tom, looking back in the past year, do you have some observations as to what some of the most common citations are, the most common impediments to accreditation? I think our audience probably wants to hear that, not even if they're not necessarily part of QuadA.
No, I think that's great, and I think it's a great smell test. We always talk about the top 10 deficiencies, and in my experience, 16 years into this life, talking to other accreditors, we're pretty consistent. If I run the top 10 deficiencies because of ties, we'll probably wind up with 12 or 13 across the board. 8 of those will be documentation.
Yeah,
they will be documentation based. I always say doctors and nurses are trained to treat people, to diagnose and treat, not to fill out paperwork. It's not what you want to do, but that's where consistency is bred, right? Yeah. Consistency. I go to the gym every day, right? If I don't document what I do at the gym, I might lift this one day, that the other day. I'm tired, I don't feel great, whatever. But if you document, you have a benchmark, right? We talk about benchmarking. So what breeds consistency is that documentation. And we try to keep it limited so it's not so bureaucratic, but we want to make sure that the stuff that impacts patients is getting documented as being done. Everything is there: bleeding tendencies, drug interactions, those types of things, concurrence of your anesthesia provider with the course of treatment, along with the operating surgeon. Yeah. Those types of documentations are always in the top 8 of the top 10 or 12, if considering ties. I'll also say with documentation, considering OR logs, narcotic logs, and even dating of open narcotics. That's a big one that we find too. Folks open a lot of times multi-use vials. They'll mark them with an open date. They won't mark them with an expired date because the expiration's already printed on. But once it's open, there's a whole,
changes the time.
It changes the timeline. So when do I need to waste this thing? That's one of the most common ones we see. Beyond that, and speaking specifically to the Medicare participating world, emergency planning is always a challenge. Yeah. Emergency preparedness is a challenge because it's foreign. It's foreign to medical providers because you're not FEMA. You're not thinking about floods and hurricanes and fires. We're all used to fire drills because we've been doing them since we were in kindergarten. But other stuff becomes important too. And so I would say those types of things become very, very challenging for people. Infection prevention is always a challenge because it requires consistency by so many people, and they're touching something that's so critical that it really is a high-level citation when you have breaches. If I was putting big categories, I'd say those are the 3 big ones. In infection prevention, I think is operationally the most critical. The other thing I would say, and this goes to especially to emergency planning, is creativity in emergency planning is important. How do you see things like, it's easy to do fire drills, but what about the types of, even if it's a bunch of types of emergencies, what's the type of stuff that requires you to evacuate versus the type of stuff that it requires you to lock down, right? If you have civil unrest in your neighborhood, if you have, a disgruntled spouse at the business next door, what does that look like versus a fire drill, which wants you out in the parking lot? But if you live near somebody that unfortunately, if you live near somewhere that's having an active shooter, you don't want everyone evacuating out to the parking lot. So thinking along those lines, which is not common to us and is not natural to us, I think is really, really important for medical providers. You don't have to have everything in mind, but you have to kind of think about the different classes, think about the types of things that happen. And the other thing that I caution people, and I will give enormous credit to the Joint Commission for this article that I think was about came out last year, and it was about consistency with your policies. Mm-hmm. One of the most common types of deficiencies I would see, if I'm not citing a specific standard, but the nature of a non-compliance, it's because facilities don't live up to what they've promised in their internal policy. Yeah. And the common pushback that we get is, show me where that's a standard. And they wrote a really great article about a year ago that talked about the levels of what any accreditor assesses, right? We're assessing towards the regulation. So if you're Medicare participating, we all have to demonstrate that we are at least as strict or more strict than the federal regulations. So baseline is the federal regulation. Then when we all apply, we submit our standards, and all of us have standards that exceed the federal regulations. But once Medicare approves our program, they're approving the whole thing. They're not saying, well, we approve the medical, the federal regulations, but whatever else you guys say is kind of irrelevant. They're approving the entire body of that program. So if we have 15 more standards about hand hygiene than the feds do, that all gets approved as well and carries that same weight. And then to take it a step further, every single organization says you have to have a policy for whatever. If you don't follow that policy, you are failing against your own promise. And the example I always give, and it's an extreme example, is if one facility says that they're going to do weekly fire drills versus whatever, monthly, right? And they've got 50 fire drills instead of 52, they're deficient. And the place that did 12 when they said they were going to do monthly fire drills is golden. Yeah. So be really cognizant of that when you're writing your policies.
When I was up in Washington State for their state association meeting, I was talking to Michon, who's pretty much the only person I ever see at these conferences. I know you do have other people, but Michon and I were talking about an exciting new program you have, and I know it doesn't touch many of our listeners, but can you talk just briefly about your Med Spa program?
Sure. Yeah. So as I've said a few times, our mission is to promote patient safety, and patient safety exists really throughout all spectrums of outpatient care or patient care entirely. And we've noticed, or we've seen an acute need, obviously, in small facilities, in outpatient surgery, where it's largely unregulated in many states, in outpatient surgery, because many specialties are kind of all over the place with the use of anesthesia. But as we go down to non-surgical interventions as well, we see dramatic variation in who's performing cases, who's providing services, who owns and oversees them, who's planning, their level of training and knowledge, not just in the services they're providing, because it's one thing to become great at the specific technique that you're doing, but it's a completely different thing to have kind of broader medical knowledge to know how to intervene if something goes wrong. And there's this huge sort of misnomer out there that nothing can go wrong, that you can't really have a big adverse event in sort of a non-surgical aesthetics and wellness and med spas and infusions. All of this stuff is sort of seen very commercially, like a nail spa or a salon, and that's really not the case. This is healthcare, and by and large, it is very, very because it's in its infancy, but it's growing at such an explosive rate. It's very all over the place. There are wonderful, great, very safe places, and there are places that I wouldn't send my pets.
Right.
And so QuadA recognized that. We've been working a lot with the industry. And so we're actually in the process right now of beta testing, of pilot testing our draft standards. They were published for public comments about 2 or 3 weeks ago. I think the public comment period is open for another, it must have been about a month ago. They're open for another 2 weeks. I think we left it about a month and a half for public comment. But we're also going out in the field to 5 facilities initially in 5 different states. We have 3 more on callback in case we need to go back out and kind of pressure test some other things. And then at the beginning of the year, we'll be releasing the final standards for this program. And it's for non-surgical aesthetics and wellness. So places that are doing men and women's, sexual wellness and health, as well as aesthetics and injectables and all of the things that we hear about on probably 50, radio ads or online ads a month. All those services, which are owned by, practitioners of all kinds. I think because reimbursement has gotten tighter, because finance has become much more dynamic, we'll say, and challenging thing for healthcare providers of all types. I think med spa services and dental spa services, which is all those services provided from the clavicle up, I guess. Yeah. All of those services are a great buffer for financial health for facilities, and they're repeat business, and they're a way to kind of keep your patients involved on an ongoing basis. And I think that's all fine and good, but we want to make sure it's being done safely. So that program is launching right now. It's in its test phase, and it will launch, in the beginning. I think we're projecting February as when we kind of go online and ready to take applications. And we've already had a tremendous amount of interest from leaders in the industry, from consultants in the industry, from practitioners in the industry, and from corporates, because these tend to be owned by a lot of PE and private equity, to see this as one, a way to differentiate between people that are doing things that are maybe off the wall or unreasonable, but also as a way to show safety to patients that maybe would be more willing to come in for services if they know that there's some quality and safety oversight, but also as a risk mitigation. Again, as a medical provider, there's malpractice insurance to be involved. There's legal liability, and to do as much as you can to show that you're protecting patients, and that even your extenders and those others who are providing services are following protocols and standards and established standards with a trusted organization, is a huge way to kind of promote patient safety and mitigate your risks, especially if you're investing in multiple sites across multiple states. It becomes that much scarier, I think. So we're excited about that program because it's a good program. We think it's an area that is largely ignored.
Yeah.
I've seen estimates that there's going to be about 125,000 of these places across the country by the time all is said and done. So it's a huge exposure point of risk to patients that could face, necrosis of skin, blindness, all kinds of really serious stuff. So it's a way to protect those patients and to not trivialize the treatment, but it's also a way to serve our mission just more broadly. And I think that's really the key, is to make sure that patients, no matter how trivial we want to make the care, they deserve to be as safe as someone who's undergoing heart surgery. And we want to make sure that we're serving that population too.
So as we come to an end here, why don't you talk a little bit about how you get in touch, how you learn more about QuadA, and just one last pitch for what makes you different.
Yeah, absolutely. So I would definitely say, we used to like to say that the sun never sets on a question at QuadA, because you'll get answers right away. I wouldn't go that far. Technology has changed our entire world, and time zones do make things different. But you're going to get an answer, and you're going to get a personal touch. And I talked a little bit about our specialists. So what makes QuadA really special is our specialists and our clinical team. Every facility has a representative that's working with them. And as all that beautiful technology comes online to make things frictionless and easy and self-service for the facility, that frees our specialists up to really become advisors and help for you. I don't want to steal any business or anything from any consultants, but I like to say that our team provides kind of consulting light or diet consulting. So if you have questions, if your consultant has questions, they work in many states and they just want to make sure they understand what's going on. If they work with QuadA, they're working with somebody who's going to have like a personal touch and a personal investment in making sure that they're successful, because that's ultimately the goal, is to take a facility, whether their bar is 20% or 80%, and just raise them. And so that's, I think, the big key differentiator. And thankfully, that technology allows our people to become even more expert at helping you. If you want to get in contact with us, it's QuadA, QuadA.org. So we still are technically the American Association for Accreditation of Ambulatory Surgery Facilities, which is a huge mouthful, and everyone called us QuadA anyway. So we just changed the name. So QuadA.org. You could find us on all social media. I think for most social media, it's QuadA now, because there's some other associations that took QuadA. Yeah. But I believe still on X, on Facebook, on Instagram, on LinkedIn, definitely. You can reach us on all of those. We have a podcast, the QuadA Now podcast. So if you're on Spotify or wherever you get your podcasts, we try to have people on that just educate not only our accredited facilities, but facilities who may become accredited, or patients, about areas of patient safety and areas of value when they're assessing healthcare facilities and providers and making their decisions about coming to just get any kind of healthcare services from anyone. If you are a facility and you're interested, there's a email address, info@QuadA, QuadA.org. Or if you have questions about our standards@QuadA.org, again, QuadA.org, you will find that that will go directly to our clinical team. So if you're kind of trying to figure out what's going on and you have a question about a standard or a requirement or what you need to do, those folks will research it. Even if your local question might be a little bit nuanced, they'll do a lot of heavy duty research to make sure they get back to you. And the other thing, I'll just make a big pitch on this, is transparency. QuadA is an incredibly transparent organization. If you can fog a mirror, you can get our standards. We're not going to charge you anything to do that. Go online, get the standards, whether you want to get accredited by us or not. get accredited by one of the competitors or not, you can get QuadA standards and assess them. There's interpretive guidance there that will help you meet the standards, that will help you understand what is important and what a surveyor will assess. And you can look at that against anybody else's standards, or God forbid, if you don't want to get accredited, if you just use it as an internal self-check to make sure you're on the straight and narrow, do that at the very least. Make sure you're on the straight and narrow and you're flying right, and at least let me sleep a little bit sounder.
Tom, this has been fantastic. Thank you so much for your time today.
Thank you so much for the opportunity, and thank you for the conversation. It's always great to talk about the organization, to talk about accreditation and our mission, and to hopefully educate a few people with what we're trying to accomplish out here. And it's not to be a pain in the neck.
Absolutely. Well, we'll make sure it's not 5 years before we have you back on again. Thanks so much.
That's right. Thanks again.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff and other events in the ASC industry.
So the American Academy of Ambulatory Care Nursing, or the AAACN annual conference, is going to be April 14th through the 17th, 2026 at the Hilton Orlando in Lake Buena Vista, Florida.
And the ASCA and SAMBA conference and expo is May 13th through the 16th, 2026 in Washington, D.C.
We're very much looking forward to ASCA 2026. Sue, I know you were working today on getting our booth there, so we're going to have a nice booth at ASCA just as we did last year. And, of course, last year we did 3 special episodes from the conference, and I expect we'll probably do the same thing this year. And the Gulf States ASC Conference, which is a combination of Alabama, Louisiana, and Mississippi's associations, is going to be June 17th through the 19th, 2026, at the Ritz-Carlton in New Orleans.
And the Florida Society of Ambulatory Surgical Centers annual conference and trade show is July 22nd through the 24th, 2026, at the Hyatt Regency Grand Cypress in Orlando, Florida.
And the CASA annual conference, California Association of Surgery Centers annual conference and exhibits, is going to be September 2nd through the 4th, 2026 in Monterey, California. I love Monterey, and we'll definitely be there, probably having a special episode also.
And the Pennsylvania Ambulatory Surgery Association's annual meeting and educational conference is October 4th and 5th, 2026 at the Eden Resort in Lancaster, Pennsylvania.
And just so that you know, we are actually in conversations with the association to see if we can attend their conference and do a special episode from there. And the Atlanta States ASC Conference, which is North Carolina, South Carolina, and Virginia, their conference is going to be October 8th through the 9th, 2026 at the Embassy Suites, Raleigh-Durham Research Triangle in Cary, North Carolina. And the New York State Ambulatory Surgery Center Association's annual conference has moved to November of 2026. It's going to be November 17th through the 18th, 2026, with a pre-conference sponsored by Ambulatory Healthcare Strategies and the ASC Podcast with John Goehle, is going to be on the 16th. So this is going to be at the Desmond in Albany, New York.
And we want to remind you to watch the ASC-Central.com website as we announce the various conferences for 2026.
So we're still trying to finalize some of these conferences. The Director of Nursing boot camp will be either in late January or early February. And then later on in the first half of the year, we're going to have our ASC Administrators boot camp. We're going to also have a one-day quality improvement conference and a human resources conference. Sorry, the dates have not yet been finalized as we try to coordinate with all of the state association meetings as well as our very complicated schedule. In addition to some renovations too that we're making to our studios here, as well as an upgrade to the software that we're using for this. So a lot of things in the air right now as we try to finalize that, but we will keep you informed as we go along. And don't forget, on-demand versions of the ASC Director of Nursing, the ASC Administrators, and the ASC Business Office Managers boot camps are available on our sister website at ASC-Central.com. And here's a reminder again for everyone to become a patron member of the podcast. Don't miss out on the benefits of joining our Patron Program, which is available at ASC-Central.com. This is a comprehensive membership platform, and it's your kind of go-to resource for all aspects of ASC regulatory and accreditation compliance, operations, and financial management in the ASC setting. It's designed with the busy schedules of administrators, nurse managers, and business office managers in mind. By becoming a member, you gain access to regular Zoom sessions, which are typically held on a weekly basis, where you can engage with other patrons and our podcast team. And then we also have a wide range of resources on our platform, which include some of our virtual conferences, such as our credentialing conference and the Conditions for Coverage conference. And you also find various valuable tools such as sample policies, procedures, forms, and disaster and fire drill kits. Your support helps us to maintain and grow the podcast, covering essential costs like research, travel, equipment, and production. To learn more and to become a member, visit ASC-Central.com.
Thank you for tuning in to this episode of the ASC Podcast with John Goehle. We hope you found the discussion insightful. If you did, please share it with your colleagues in the ASC community and be sure to subscribe so you never miss an episode. We appreciate your feedback and suggestions for future topics. Reach out anytime at comments@ascpodcast.com. A special thank you goes out to our incredible team, sound editor Susan Cronkite, executive producer John Goehle, and our committed research team, Sue Cronkite, Jenna Alvarez, Judy D'Ambrosio, Mike D'Ambrosio, Zach Kaloritis, Jim Masters, Stuart Rosenberg, Amy Cronkite, Lori Rodericks, Kathy Fody, Donna Macchio, Christina Norman, and Katie Pearson. Your hard work makes this podcast possible. Our theme music is by Media Sushi and Mike Noah. The ASC Podcast with John Goehle is hosted on Podbean and can be found on all major podcast platforms. Thanks for listening, and we'll see you in the next episode. This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, RFX Solutions, MedServ, and Ambulatory Healthcare Strategies. Surgical Information Systems provides cutting-edge information solutions for surgery providers. RFX Solutions is your all-in-one healthcare regulatory compliance software. MedServ, which offers the only digital narcotics cabinet specifically designed and priced for surgery centers, helping develop standardized processes and compliance, eliminate paper logs, and prevent drug diversion. And Ambulatory Healthcare Strategies is the nation's leading regulatory and accreditation compliance resource for ambulatory surgery centers. For more information about our sponsors, visit our website at ascpodcast.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.